She woke up drenched in sweat at 2 in the morning, again. She counted back 6 months of broken sleep, the hot flashes that made her leave meetings early, quietly, hoping no one noticed, the fog that settled in every afternoon right when she needed to think clearly, the irritability she apologized for over and over to people she loves, the exhaustion she had learned to call normal, the way you learn to call anything normal when it goes on long enough. And she never said a word to her doctor. Not because she didn't know something was wrong. She knew. She'd known for months. She had noticed when it started, tracked how it shifted with the seasons, noticed how it was worse in the weeks before her period, and then worse again after. She had done the mental math of what she was losing: hours of sleep, concentration at work, patience with her family, physical comfort in her own body. She didn't say anything because she had quietly decided that this was just what midlife felt like, that her doctor had real patients to worry about, that she didn't want to seem dramatic, that maybe if she just gave it more time, it would pass on its own, that maybe she should just push through. She is not the exception. She is, according to a 2025 study published in Mayo Clinic Proceedings, the overwhelming rule. Researchers surveyed nearly 4,000 women between the ages of 45 and 60 across 4 Mayo Clinic primary care locations across the United States in Minnesota, Arizona, Florida, and Wisconsin. These weren't women without healthcare access. These were women already in the primary care system, already seeing physicians regularly, already within reach of a conversation. More than 3 out of 4 of these women were actively experiencing menopause symptoms. And of the women with moderate to very severe symptoms, the ones who were genuinely struggling, the ones whose daily lives were measurably affected, 87% had never sought medical care for those symptoms. 87%. Let that settle for a moment. This is education, not medical advice. If you are managing symptoms that are affecting your daily life, your sleep, or your ability to function at work, that conversation belongs with your healthcare provider. But today's video is not a list of symptoms. You already know what they are. Today, we're going to talk about something harder. Why so many women already know something is wrong, already feel the impact every single day, and still never ask for help. Why the decision to stay quiet feels to the women making it completely rational. And why that rationality itself is the symptom of a much larger problem. Because this gap between suffering and care is not a personal failure. Drop a comment right now with just your age and the word "seen." Nothing else. I want to see who needs this video today. Because here's what the Mayo Clinic data makes clear. This silence isn't about individual women making bad choices. It's about a system that has spent decades communicating in 100 small ways that menopause isn't serious enough to treat, that women who bring it up are being difficult, that learning to manage quietly is the expected and appropriate response, and women, being perceptive, being socially aware, being attuned to the signals around them, received that message exactly as it was sent. And that gap between suffering and care is costing real people real quality of life every single day. Nobody told you that this silence had a structure, that it wasn't personal, that millions of other women were sitting in the same quiet at the same hour, having made the same private decision not to speak, that the system wasn't designed to invite this conversation, and that its failure to do so has been documented, measured, and published in peer-reviewed medical journals. Today, we're going to change that. Here is what made the Mayo Clinic researchers stop. They weren't just tracking whether women were receiving treatment. They also asked the women who hadn't sought care to explain why. They gave them space to name the barriers. And the answers weren't what most people would expect when they imagine why someone might not seek medical care. The most common reason? Being too busy. The second most common, not knowing that effective treatment options even existed. Not "I couldn't afford it," not "my doctor turned me away," Not "I was afraid of side effects." The most common answers were the simplest ones. "I didn't make the time, and I didn't know there was anything that could help." Write this down, because this tells us something critically important about the nature of this problem. It tells us that the gap between suffering and care is not primarily a problem of access or insurance or geography, though all of those things absolutely matter and compound the issue for many women.
The gap is significantly a problem of information and normalization, a problem of what women have been led to believe about what menopause is, what it does to the body over time, and what can reasonably be done about it. A problem of women having quietly internalized the message that their symptoms are an inconvenience to be managed, not a medical situation to be treated. And the numbers make this even harder to look away from. The study found that 34% of surveyed women reported moderate, severe, or very severe symptoms. Sleep disturbances and sexual health problems were among the most frequently rated as severe or very severe. Two categories of symptoms that have measurable, cascading effects on cardiovascular health, cognitive function, mood, and quality of life. And yet, the researchers note directly, menopause symptoms remain under-recognized, under-treated, and inadequately addressed in the healthcare system. Not in some countries with limited medical infrastructure. In the United States, at Mayo Clinic primary care sites, among women who already have a doctor. The researchers also noted something that every woman who has ever sat in a waiting room might recognize. Women often do not voluntarily mention concerns about menopause symptoms to their healthcare provider. They don't bring it up. They answer the questions they're asked, they nod through the routine parts of the appointment, and they leave without ever naming the thing that has been disrupting their life for months or years. Not because they forgot, because they had already pre-sorted those symptoms as not worth the conversation. Because they had already decided in the quiet before the appointment that this probably wasn't what the visit was for. This is not a small detail. A woman who spends 6 months waking up drenched in sweat, losing hours of sleep every night, struggling with focus and mood, missing days of work, and still walks into an annual physical and says, "I'm doing fine." That's a communication failure that has a context, a long, complicated context that took decades to build. Before I get to what that context is, the part that I think explains almost everything, there's something else in this data worth sitting with. The economic cost of unmanaged menopause symptoms is estimated at $1.8 billion a year in the United States in productivity losses alone. When direct healthcare costs are added, that figure rises to more than $26 billion annually. And roughly 10% of women aged 45 to 60 reported missing work because of their symptoms, averaging 3 lost days per year, though researchers note this likely significantly understates the real impact when you account for women who showed up but couldn't perform at their usual level, or who quietly stepped back from responsibilities they used to manage easily. 1 in 5 who did seek care were acknowledged by their provider and then not taken seriously. 1 in 5 who sought care were dismissed, minimized, or referred elsewhere without clear guidance. These are not isolated incidents. These are documented patterns. If you have ever left a doctor appointment feeling like your symptoms were redirected or treated as an afterthought, drop a comment and tell me what happened next. I want to hear it, because that experience, as personal as it feels, is a data point in a much larger pattern. Here's the part nobody told you. Menopause is universal. Every woman who lives long enough will go through it. It is not an edge case. It is not a rare condition. It is not something that affects a small or unusual subset of patients. It is a physiological transition that affects half the population,
Approximately 1.3 million women in the United States enter this transition every single year. By 2025, an estimated 1.1 billion women globally were postmenopausal. And in a 2024 global analysis of medical textbooks, 58% contained no mention of menopause at all. That number is worth letting land. 58% of the medical textbooks used to train the physicians who will see midlife women in their clinics. No mention, not a chapter, not a section, not a paragraph, nothing. Among U.S. obstetricians and gynecologists, the specialists most likely to be managing the reproductive and hormonal health of midlife women, only 1 in 5 report having received formal training specifically related to menopause. And as recently as 2024, 72% of surveyed menopause specialists reported that newly qualified healthcare providers were not being given adequate education on the subject. This is not a judgment of individual physicians. Most are doing exactly what their training prepared them to do. The problem is that the training itself had a significant gap, and that gap is now walking into clinics every day in the form of midlife women who need care they're not being offered. Write this down.
The reason so many women have normalized their symptoms isn't that they lack awareness or intelligence or self-advocacy. It's that the cultural and institutional systems around them spent decades modeling that normalization as the expected response. You don't seek care for something that everyone around you treats as inevitable and unremarkable. You don't name something a problem when the dominant message from media and from medicine alike has been, this is just part of getting older. This is what women go through. This is manageable. That framing has real consequences. When the message is just manage it, women manage it, quietly, alone, at significant cost to their health, their careers, and their quality of life. The Mayo Clinic data shows that 45% of women aged 35 to 54 report hearing about menopause on social media, while only 34% heard about it in a clinical setting, and 22% report finding it actively difficult to access reliable information about menopause or perimenopause. So for a significant number of women, the primary sources of information are platforms with no accountability for accuracy, wellness content monetized around fear and expensive supplements, and a culture that still largely treats menopause as either a punchline or a private suffering, something to be handled quietly, not discussed openly. And then they arrive at a 15-minute appointment with a physician who may never have had a single course on this subject. The researchers from Mayo Clinic are calling for strategies that destigmatize menopause care and make it more visible and accessible. That language, destigmatize, is clinical, but the meaning is deeply personal. It means, right now, women are walking into appointments having already pre-sorted their own symptoms as not worth the time. They are protecting their doctors from a conversation their doctors may not have been trained to have. They are carrying the weight of a systems gap in their own bodies every single day and calling it normal. That is a broken loop. And here is what breaks it. Not one study, not one conversation, but a cumulative shift in what women feel entitled to ask for and what the healthcare system feels prepared to address. And that shift starts with naming the problem accurately, not as a personal failure, not as individual women not trying hard enough, but as a systemic gap that has been costing women quality of life for decades, that has been documented, that is understood, and that is finally being taken seriously by the medical community in a way that it has not been before. Nobody told you that this was treatable. The system wasn't built to tell you. That is not okay, and it is changeable. Because the research on what helps is actually clear. The evidence base for menopause treatment is substantial and continues to grow. What has been missing is not the medicine, it's the conversation. And a conversation requires two things:
a woman willing to ask, and a system prepared to answer. The first part of that equation is what we can begin to work on today. Here is what that shift looks like in practice, not as a motivational list, as 3 specific things you can do with real numbers and real mechanisms behind them that move the conversation forward for you specifically. First, name your symptoms before the appointment, not during it. Most women who have minimized their symptoms in an exam room did it in the moment, under the pressure of limited time, the social awkwardness of a brief interaction, the ambient sense that this wasn't what the appointment was actually for. The Mayo Clinic researchers specifically flagged that women often do not voluntarily raise menopause concerns with their provider. The solution is not more willingness in the moment, it's preparation before you walk in. Write down the 3 symptoms that are most affecting your daily life right now. Rate their severity on a scale from 1 to 10. Note how long they've been present. Bring that paper. Hand it over before anything else happens. You have now changed the structure of the appointment. You have made it harder to move past. You have named the conversation instead of waiting for someone else to start it. Second, understand that effective treatment options exist and have for decades. Only 1.8 to 5% of eligible women currently use hormone therapy for menopause symptoms. This is a dramatic underutilization of an option with an extensive evidence base behind it. The hesitation that became widespread traces back significantly to a 2002 clinical trial, the Women's Health Initiative, whose initial findings were reported and amplified in ways that significantly overstated the risk for the majority of the women who might have benefited from treatment.
The current clinical consensus, built on 2 additional decades of research and more careful analysis of who the original study actually studied, is substantially more nuanced. This doesn't mean hormone therapy is appropriate for every woman. Individual history, timing, and risk factors all matter enormously. It means the decision deserves a real, informed, individualized conversation, not a silence that has persisted based on a misread headline from 20 years ago. And hormone therapy is not the only conversation available. There are non-hormonal options with good clinical evidence, including one FDA-approved treatment specifically for vasomotor symptoms, hot flashes, that works through an entirely different biological mechanism. There are lifestyle and behavioral approaches with documented effectiveness for specific symptom clusters. The landscape is wider than most women have been told. The conversation has options. You deserve to have the full conversation. Third, if you are not heard, you are allowed to try again. 1 in 5 women who sought care were dismissed, minimized, or referred elsewhere without meaningful guidance. That is a documented pattern in the data, not an anomaly, not a reflection of something wrong with the women who experienced it. A woman who leaves an appointment feeling unheard has not received a medical verdict. She has received a single interaction that did not go the way it should have. She is allowed to go back. She is allowed to bring her written symptom list a second time. She is allowed to ask explicitly and clearly, "I need to talk about how menopause symptoms are affecting my daily life and my sleep. I would like to understand what treatment options may be relevant to my situation. I would like this to be part of our conversation today." That is not aggressive. That is not difficult. That is informed participation in your own health care. You are not a passive recipient of medical decisions. You are an informed participant in your own health. And if the system around you has spent decades teaching you to be quiet about this, to minimize, to pre-sort, to push through, then what we're describing right now is unlearning something that was never true in the first place. It was a failure of the system that became, over time, a belief about yourself. And that belief is worth replacing with something more accurate. Let me take a moment to recap what we covered today. 87% of women with moderate to severe menopause symptoms never sought medical care.
The most common reasons were being too busy and not knowing that effective options existed. The medical education system has a documented gap in menopause training. 58% of medical textbooks contain no mention of it, and only 1 in 5 gynecologists in the United States report formal menopause training. Social media has become the primary information source on this subject for nearly half of midlife women. And 1 in 5 women who did seek care was not taken seriously by their provider. That is not bad luck. That is a pattern with a structure. And patterns with a structure can change. Drop "informed" in the comments right now if this video gave you something real today. And share it with one woman in your life who is quietly managing symptoms she has never named out loud. She needs to see this too. Because the more women who have this information, the harder it becomes for the silence to continue. Coming up soon, the menopause treatment options your doctor may not have brought up, and why that conversation is meaningfully different today than it was 10 years ago. Stay with us for that one. This is education, not medical advice. Every treatment decision, whether it involves hormone therapy, non-hormonal medications, lifestyle adjustments, or any combination, belongs in a conversation with a qualified healthcare provider who knows your specific history, your risk profile, and your individual situation. If your symptoms are affecting your quality of life, that conversation is worth having. You do not have to push through alone.